by the way, these terms are never very precisely used, but the idea of a complete SCI is that there's been a complete transection or the equivalent of a complete transection at some specific level. So remember, the cord is specialized in along a couple of different axes. It's functionally specialized in the anterior posterior direction. And then remember, when you move your right hand, which side of your brain is controlling that? The left. And we'll talk about that. So there's a hemispheric laterality to the spinal cord as well. So in a complete spinal cord injury, the notion is the patient has lost both sensory and motor function in the right and the left sides, distal to the level of the lesion. Distal to the level of the lesion. And that sometimes, that can happen. You'll have spinal patients and following everything from a car accident to a diving accident or whatever. And we'll talk about that in just a moment. But more common are the incomplete spinal cord injuries. And again, part of your burden, I think to a large extent it will be your burden, is to assess the degree of disability, whether it be short-lived or irreversible, associated with the trauma at a given level. It may be on the right side, it may be on the left side, it may be primarily sensory, or it may be primarily motor. So by an incomplete injury, we just mean that there's not a complete transection. It's partial, it may be hemilateral, it may be anterior. But of course, in addition to whatever imaging is done, there has to be a functional assessment, and I wouldn't be surprised if that often rests upon your shoulders. They keep changing the terminology with respect to whether 2 or 4 limbs are involved, and I never know what terminology to use. I have paraparesis and quadriparesis up here. You often see tetraplegia or paraplegia. I think this is the preferred terminology now. But in any case, the implication is that depending upon the level of the spinal cord injury, either only the lower limb will be involved, or both the lower limb and the upper limb. And what is the most likely site of spinal cord injury? What is the most likely site? Yeah, cervical. So which is more common, the tetraplegia or paraplegia? Tetra, yeah, for that reason. So the only other thing, again, I'm not going to ask that you memorize this table, but you can see, as we saw in the previous illustration, that if the transection is well, we'll see different indicators, but in the region of C4, even C5, that's the respiratory pathway. Those are the cervical plexus pathways that go to the diaphragm. So mechanical ventilation may be required in that case. And then as we get down to the thoracic region, then you're looking at more frank paraplegia involving only the lower limb.
Is tetraplegia the same as quadriplegia?
Yes, as I say, I've given up trying to give you the fashionable terminology, because I'm sure that whatever I tell you will be changed in your clinical courses. But yeah, tetraplegia, quadriplegia. Yeah.
Is there a distinction between the suffixes paresis and plegia?
No, that's what we're just talking about. No. There's no important distinction in the clinical literature that I'm familiar with. Now, these are what students and I sometimes call placeholder files. Now, we've already talked about this material in the other course. I just want to remind you, when I put these slides in here, that you're responsible for an understanding of the meninges and whatever other topic is on the slide. So I don't think we need to talk too much about the meninges, but you certainly need to be familiar with the organization of the meninges and be able to tell me all about subarachnoid space and why it's important. You should be able to differentiate, or at least know what we mean by a meningeal potential space. And the fact that the meninges extend on down to the cord, all through the cord. We've talked about the blood-brain barrier, and in a previous slide, we talked about the contribution of the astrocytes to the blood-brain barrier. And in the little graphic on the right, that's what we're looking at here. These are astrocytic foot processes here. There's one there, there's one there. And so these are the astrocytic foot processes that you can see virtually circumscribing a capillary. So this would be a capillary vessel here. And so in this illustration, the astrocytic foot processes are, through a variety of transport mechanisms, all of which you are familiar with now, are taking substances from the systemic blood, processing, filtering, refining those, and then delivering them to the nervous system. So the astrocytic processes are an important component of the blood-brain barrier. Now this is a conventional capillary. This would be the type of capillary, for example, that you might find running through skeletal muscle tissue. And you can see in this capillary, we have a simple squamous epithelium. Yeah.
Are dysfunction of these astrocytes a common cause of meningitis? Is that how the infection would get treated?
No, we're in the brain now. So when we talk about meningitis, if I understand your question, the meninges would be the capsular layers of the CNS. So around there, that's the little recording.
There's no astrocytes in your meningeal.
No, these are the cells that are in the interior parenchyma of the brain. So you have neurons here. So yeah, this would be we're in the cortex, if you will, sort of the cortex at this point, or elsewhere in the gray matter of the brain. Now, this again is, you can see simple squamous epithelium. It's called the capillary endothelium. And at various points, you see little openings here. The openings are called windows. The Latin term is fenestra. Fenestration, and probably all of you know some portion of the Latin language, and that word is fairly common to indicate that. So a typical capillary elsewhere in the body is going to have these fenestrated. We say that this capillary endothelium is fenestrated. This is a fenestrated capillary endothelium and allows fairly large substances to pass through. This facilitates nutrition of surrounding tissues and so on. Now, compare that to the capillary of the brain. We call this a non-fenestrated capillary endothelium. You don't have these frank or patent openings. If something is going to get from the blood to the astrocyte, eventually to the neuron, in general, it has to be acquired through specific transport processes. And boy, there's a host of these. Remember, your nervous system is consuming about 20% of your total metabolic energy just sitting there. And this in part is why, to power all of this transport, along with a variety of other processes, the neurons just tend to be energetically inefficient for a variety of reasons as well. But these are the two primary components of the blood-brain barrier: the astrocytic intermediaries between the blood and the nervous system, and the non-fenestrated high transport activity capillary endothelium. All right, this morning we also talked about the CSF. You know, you can identify at this point the lateral ventricles, the third ventricle, and the fourth ventricle. Remember, it's a little bit hard to see this, but both the third and the fourth ventricles are just tiny little sheets, just basically just very, very thin little structures. You have the anterior horns, the posterior horns, and then you have fairly limited, and this is important because in a lot of pathologies of CSF circulation, this is your bottleneck here. There's going to be a bottleneck here, but more commonly in this region here. So, and you might imagine what would happen if the ability of the CSF to circulate throughout the nervous system is impaired. So my point is just to be able to recognize the ventricles. You can see that they have this very characteristic C shape. We're going to see that a number of structures in this region have this sort of C shape around the center of the brain. Now I do want you to know a little bit of the volume present in the central reliquaries of CSF. For example, the ventricles by themselves contain about 40 mils there's about 150 mils of CSF in the entire CNS. But this is kind of remarkable. If you're paying attention to the numbers, about a half liter is produced daily. So about a half liter of CSF is produced daily. So how can you reconcile these numbers? A half liter is produced, and there's less than 200 mils in the entire system. What must be going on? Yes, very rapid generation and reabsorption. This fluid is turning over at a fairly high rate. And we've already talked about the fact that the CSF is filtered, the filtrate is formed at the choroid. And we talked about the locations of the choroid. In fact, in this illustration, you can see it here, the little red things. And here especially at the fourth ventricle. And then also in this illustration, you see the general axis of circulation. Don't pay attention too much to the direction of the arrows, but make sure you understand that CSF is circulating through the central canal you see there, and in the subarachnoid space surrounding the cord, and that applies to the brain as well. Now, the other thing I want you to pay attention to is the composition of the CSF. It's sort of summarized here, but I put a little table in here. So if you look at the table, remember the CSF is a filtrate of the blood. You look at the sodium concentration here and the chloride concentration, they tend to be a little higher than that of the blood. But what do you notice about everything else? It's lower, considerably lower, especially, let me erase those two because I want you to pay attention to these. Notice that in the CSF, the carbohydrate concentration, the glucose concentration, and protein concentration are dramatically lower, such that, if you look at the two numbers, these can often be diagnostic of what? If these numbers go up in the CSF, what might you suspect? Yeah, there's probably some blood leaking in there somewhere. Function of the CSF? Yes. Oh, it could be any number of locations. I'm sorry, because you're snoring already. I'm going to film this one. I'm getting ready to snore as well. The question was, where would there be leakage between the blood supply? It could be at any part of the brain where that blood-brain barrier is present, anywhere there might be an interface. This whole region is so heavily vascularized. But it really, I was going to say, oftentimes tumors can cause this, strokes can cause it, physical head trauma, just any number of things. And part of the burden between you and the neurologist would be to correct it, locate the problem and correct it. And of course, if that's present, oftentimes that fairly clear cerebrospinal fluid will no longer be clear. Oftentimes you'll see evidence of bleeding in the fluid when the TAP procedure is done. In terms of the functions, we often say that the CSF is a buoyant medium. When you get out of a swimming pool, how much heavier you feel when you leave the pool. So the CSF provides some measure of hydraulic protection for the brain as it bounces around in your head. One of the unfortunate things, I'm very familiar with what happens as we age. One of the unfortunate things that happens as we age is our brain shrinks. And quite literally, as we age, our brain starts sloshing around inside the skull to a greater extent. And so I for one, am particularly grateful for my CSF upgrade because it would just be a jarring experience to have your brain rattling around unnecessarily as it is inclined to do anyway. And of course, we talked about contra-coup injuries that the CSF tends to provide protection against that type of any type of traumatic deceleration or acceleration type injuries. And then the CSF, we've indicated, also plays a role in nurturing the entire central nervous system. Here we just simply have an illustration of the arachnoid villi. I just want to make sure you understand here and you can identify the various components here. So notice that this structure is this structure right here. So we're looking at a structure that lies between the periosteal and the meningeal layers of the dura mater. This would be venous sinus blood here, and as the arrows are indicating, the CSF is moving from the subarachnoid space through the epithelium of the arachnoid granulation into the blood, back into the blood where everything's going to be reprocessed again. Arachnoid villi and villus. And you can see these things are all over the place there in the sinus and then even off to the periphery from the sinus.
So it's not absorbed through there, it's absorbed.
When you say it, what do you mean?
It says that the CSF is reabsorbed by the arachnoid villi. But then,
No, it says it's reabsorbed back into blood vessels by
so where is it reabsorbed from? The
yeah, it's you see the arrows here. So, excuse me as I tumble. It's moving from the subarachnoid space, which is all this is. This is at a higher pressure through the arachnoid endothelium back into the venous blood, where it just returned to the general circulation. All of this venous blood, as we're going to find out in the next anatomy class, basically ends up in your jugular veins and just goes right into your back into your heart. So you can see the choroid, those red regions are intended to represent the presence of the choroid. Now we've already made the point that this, when we look at those numbers, the 40, the 150, and the 500, this volume must be carefully maintained, carefully preserved. We talked about the role of the ependymal cells at their various locations, having the ability to both propel the fluid and absorb and secrete it. So they play an important role too. But we've also pointed out that there are several anatomical bottlenecks in this tissue, and that if the circulation of CSF is significantly impeded for any reason, that can have very severe adverse consequences, such as hydrocephalus. What do we mean by hydrocephalus?
Water on the brain.
Well, yes, but we know literally you don't have water on your brain unless you just happen to drink too much like me. What do we mean by water on the brain?
Increasing cranial pressure.
All right, so what's causing that increased pressure?
That CSF.
Yeah, the CSF. And you might think, especially those ventricles, in the most severe cases, the CSF is accumulating in the ventricle. And as it does so, it's displacing neural matter towards it, compressing it and pushing it against the walls of the skull. And yeah, that can be extremely destructive. Yes, in the worst cases of hydrocephalus, there's no brain. If a child, a neonate, is born with frank hydrocephalus, there's no brain there at all. But that's not what we're talking about here. Don't worry about this too much. This is just pointing out that the choroid is also present at this region right in here in the fourth ventricle. And then up here, we're looking at an axial view, a transection of the brain. And what they're showing us is this is the floor of the lateral ventricles here. And if you look at that, you can see the little ridges of choroid there at the base of the.
Right.
So this is what I was talking about. These are ventricles that have been enlarged by the presence of a colloid cyst at this region here, where the CSF should be draining down to the third ventricle and so on. This little island, this little cystic island, is preventing that. And so as the CSF accretes, it's compressing the white matter and the gray matter. And this, again, can be just, can have very tragic consequences. This often, I hesitate to use the word often, but I can't tell you how many times I've encountered this just teaching, and I know it's going to be a much more common observation for you. But for example, a student following a car accident, automobile accident involving head trauma, often will have a CSF shunt in place. Now, what do we mean by a CSF shunt?
It's a VP shunt, ventricular peritoneal shunt, goes from the ventricles down into the peritoneal cavity.
Yeah, exactly. So some of us may be bedazzled by your excellent terminology. But again, this means that the CSF needs to prevent that compression from occurring. A shunt is placed in a little tube, in this case, that drains the additional CSF into the thoracoabdominal cavity, where it can be resorbed there. There's no problem. I probably over the years have seen at least a half a dozen cases where students have talked about problems with their shunts. And in most cases, it was following some type of car accident or athletic injury involving the head. And then this is what I was talking about too. My brain is on the left, yours is on the right there. And you can see what happens. Not only do the ventricles get big as we age, but this is even more depressing. So what we're going to learn as we talk about the neuroanatomy here, we're going to learn that the little convolutions that you see here, these little projections, those are called gyri. Gyrus is singular, gyri is plural. And then between the gyri are sulci, or sulcus is singular. So there'd be a sulcus, sulcus, sulcus. So as you look at the illustration on the left, what do you notice about the gyri and the sulci? Did the gyri get bigger or smaller? The gyri gets smaller, the sulci get bigger. Everybody see the difference there? And yeah, why? What's happening in the aging? Well, what is the cause of the atrophy? By the way, this was just reported again last week. It's been I don't know that this has ever changed since I've been studying this. But for some reason, this was reported as a significant discovery again last week. What is the cause of the reduction in the volume of the brain with aging? What are the possibilities? As you age, what could be happening to your brain?
Shrink.
All right, when you say shrink, tell me what could be causing the shrinkage. In other words, does it seem plausible that you're just losing neurons? Yeah. Everybody agree? This massive cell loss? As you watch me, I have no trouble believing that. That seems perfectly plausible.
Neurons aren't they like only 10%? I feel like it would be more important if the surrounding structures is what's really
Neuroglia.
All right. Sounds like plausible pieces. As it turns out, the only point I want to make here is that no, there is not. As you look at me, there is not massive cell loss. What happens is both the neurons and the neuropile shrink. They just get smaller. And the reasons for that are not entirely clear. But study after study after study. Now, there is some degree of regional cell loss. One of the more fascinating studies reported in the last month. Remember our discussion of the 5-HT receptors? What's the 5-HT receptor? Excellent, good, serotonin. And then we know that part of the problem with serotonin receptors and our ability to correlate that with their abundance with depression is there are many different types. There are 5-HT1, 5-HT2, 3, and so on, and even subtypes of those. Now here's what was discovered recently that is really troubling. Serotonin levels are linked more closely, how can I say this? There's a higher correlation between brain serotonin levels and this process I'm going to talk about next than any other factor we know about. And the process is brain stem cell activity. So in other words, when I was studying neuroscience, even 20 years ago, I would have been telling you that when brain cells die, there's no replenishment, there's no regeneration of brain cells. We call them post-mitotic. They do not regenerate, and so that's that. But what we found out in recent decades is that especially in regions around the ventricles and the hippocampus and some other regions, there's very active mitosis going on all the time. These stem cells are regenerating and they're differentiating into other types of cells. Now, pay attention to what I said a moment ago. What's the primary predictor of that process? What's the primary corollary that we can find, we can detect? Yeah, serotonin levels. So the consequences of that for mood may even be less important than something like this.
So when taking SSRI, keep that process.
Yeah, I mean that would logically follow, wouldn't it? Even if there's no See, that's what we don't know. I mean, if there is an effect in some people on depression, is it because of what's the word I'm looking for? The ability of that serotonin to induce cell regeneration. I talked with somebody in the office about this. One of the things that happens in depression, especially in children, is their hippocampus. We're going to be talking about the hippocampus shortly. Shrinks. It decreases in volume in depression. So what should you do as a PA? What should you recommend to the child or to the parents to? Of course, the hippocampus, again, is important for memory and acquisition, learning. So what could you do? I guess, and it probably is useful as anything. I'm not sure there's much evidence to suggest all this stuff about what is it, baby Einstein? They have baby Einstein for old people too. And there's a company that advertises on NPR all the time that's really been in trouble legally because they can't prove any of their contentions, and we don't really have a strong FDA to handle that sort of thing. But the point I was going to make, let's just say the child's brain, the child's hippocampus is shrinking because of some depressive condition, wouldn't you be inclined as a PA to recommend SSRIs?
Yeah, but they are generally frowned upon.
You're in trouble now. I'm telling you. So what was your complaint?
There's antidepressants in children treat. I mean, I don't know if they don't work or if they're dangerous or they cause kids to commit suicide more than they cure depression. I mean,
Yeah. So you see the problem. And this recent discovery only confounds our confusion because we didn't know that it had this effect as well. But anyway, I've ordered a whole box full of serotonin because I want to avoid this as much as possible.
well, I have a question about that. This is whatever, top topic a little bit.
Never happens in here.
If you say that the highly mitotic areas are around the ventricles, how come in the 87-year-old the ventricles are larger?
Yeah. The ventricles are larger because everything else around them is shrinking. It's not as if this is not really hydrocephalus. And again, what seems to be implied is that obviously everything's going to pot in the elderly brain, including serotonin levels, probably being depressed. And if this mitotic induction is diminished, then this may be a reason for that as well. Yes.
Don't SSRIs do they reduce the total serotonin level, or is it just because they reduce the amount that's back in the?
I can't believe that was probably a divine thunderbolt to rectify you after the first test. Surely you're not asking the effect of SSRIs on serotonin levels. That's not an acceptable question.
It just keeps it in the clot longer, but does.
Yeah, it would increase the circulating concentration.
Right, so
Well, that's theoretically what they do. There's still some debate about it.
So when you're saying this new study is saying that serotonin is important in inducing cell regeneration with stem cells, so SSRIs causes too much serotonin, so that's would affect.
No, I would probably argue the other way. I don't know that we have a good handle on all the regulatory processes for serotonin, because if we did, we would know more about depression. And so what we're saying is that serotonin levels are correlated with increased stem cell activity, with increased cell division at these critical areas. That's about all I can say about the study, the findings of the study. And we don't really know what that means. But my guess is it's going to be important, like the putative discovery of the lymphatic system in the brain too. We're talking about. There's a lot of studies out there to show that one of the best things, brain exercise is heck with brain exercise. That's painful and unnecessary. Just exercise. Physical exercise is one of the best things you can do to promote brain health. Of course, that's not very pleasant either. The 9-mile rule. Everybody following the 9-mile-a-week rule? You should be walking at least 9 miles a week. Everybody out there, Fitbit, Gear, do Apple Watch. Anybody wear the Apple Watch to the test today? They were supposed to vaporize you. It was supposed to be prohibited. I don't know if Professor Patch talked about that or not.
I think all the watches are prohibited.
The Apple Watch is worse because you can tap on it and somebody else can feel your taps. You can also draw pictures on it. So we have malcreants and evildoers in here, just like everyone else.
You've been called out.
All right. So let's turn to a discussion of neuroanatomy now. I was talking about gyri and sulci. So we're looking at this is a sagittal section, this is the cortex out here. We've already seen in previous illustrations that the cortex of the human brain is relatively thin, on the order of just a few millimeters. Interior to that cerebral cortex, that gray matter that you see here is white matter, and most of the volume of the brain is white matter. All right, we can also see the gyri and the sulci. These are the gyri. We'll talk about, you'll need to know a few of these, and in between the gyri are the sulci. What's that film that's overlying, the film that you see here that has the kind of glistening appearance? What is it? Not the pia, the arachnoid. Yeah, the arachnoid. Remember, the pia would go all the way into those. You wouldn't be able to see that, but only the arachnoid sort of overlies the sulci. We'll look at a little Lackland video in the anatomy class next time to clarify that. All right. As we begin talking about all of this, again, you should recognize the cerebellum back here. Cerebellum is a little brain. It really means all this is the white matter here, sometimes called the arbor vitae or the tree of life because it's so beautiful and efflorescent. Here's the brainstem right here. We're going to be talking about the brainstem in a moment. The brainstem consists of three components: the medulla or medulla oblongata, the pons. Notice there's an anterior projection of the pons, and then the midbrain up here. These are the three parts of the brainstem. Superior to the brainstem, resting right on top of it, is a structure called the thalamus. And then remember in our anatomy when we talked about the diaphragm ocelli and the Turkish saddle, here's the pituitary gland and hypothalamus right in here, all bundled together. Don't confuse that with the pineal. Pineal would be back here. And then here's our ventricle, and here's our white matter pathway between the two hemispheres called the corpus callosum. And then again on top of that is the cerebral cortex. And you can see in the section here, you can see the ventricle we've been talking about. Here's the brainstem, midbrain here, pons, medulla, cerebellum here. Based upon our anatomy this morning, what is that right there? Excellent, the tentorium. Tentorium cerebelli. This student didn't do well on the first test. With respect to the functions of the brain stem, remember everything that goes, all the pathways between the brain and the body have to go through the brain stem. These are both motor pathways and sensory pathways. We're going to find that there are frank sensory processing structures, especially in the midbrain. By that I mean that this is something. The brainstem is sometimes called the reptilian brain, and it's basically just a very rudimentary brain that enables you to respond to the environment in a very reflexive fashion. We'll talk more about that later, but I just want you to know that sensory pathways, many of them, in addition to wherever else they go in the CNS, often go to the midbrain as well. The medulla is critical, especially in your line of work, because as this reptilian brain, as this fundamental brain, the medulla has the ability to regulate fundamental heart rate, respiratory rate. We call those the vital centers. So one of the questions I'll have for you later is how do you treat, how do you deal with what is called a brainstem patient? Remember we talked about a decorticate cat. Brain brainstem patient is a patient who has no higher EEG activity, but their brainstem is still intact, and consequently they're going to have, at least for a time, a normal heart rate, normal ability to breathe, but nothing much else. But I just want you to understand now that the medulla is chock full of these vital centers that regulate fundamental homeostasis. And then the final point, we talked about this before, remember most of the major neurotransmitter systems radiate from the brainstem. We talked about the RAFI nuclei for the adrenergics. We talked about the locus coeruleus, the ratinuclear serotonin. We talked about the dopaminergic pathways radiating from the midbrain substantia nigra. So most of these pathways radiate from the brainstem to higher regions of the brain. Let's look first at the medulla. We talked about some of the important functions. Now, let's see if we have an illustration of this. Yeah, you can sort of see it here. So let's talk a little. Here we are. Here's the medulla down here. And we're looking at it anteriorly. These are called the medullary pyramids. If you paid any attention to our discussion of motor pathways, what do you think might be running down the medullary pyramids? Which motor pathway? Which motor pathway was called the pyramidal tract? The corticospinal tract, exactly right. So that's where that terminology came from. These are your major, remember, this is anterior. And then I've asked you several times that your left arm is controlled by which side of your brain? All right. So in order for that to happen, those descending motor pathways must cross over from one side to the other. That crossing over is called decussation. Decussation. And I would say for motor pathways, about 75 or 80% of those pyramidal pathways decussate right here. You can see parental decussation. It happens right there in the anterior medulla. In fact, if you look very closely, you can actually see some of those crossing pathways. We won't worry about this too much right now, but notice that down here, a lot of these cranial nerves are emerging either from the medulla or from the region between the medulla and the pons. Nuclei for 5 cranial nerves. Now, what is the definition of a CNS nucleus? Aggregation of neurons of similar function. So what we mean is that the nucleus for each of these cranial nerves, as it leaves the brainstem, is aggregated or located in the medulla oblongata. On the dorsal side, we have nuclei for sensory function, inchoate or initial sensory processing. And then we'll look at the olivary nuclei, are not terribly important for the current discussion. These are primarily critical for your ability to interact with the cerebellar circuits. And the cerebellum is very important in your ability to refine motor function. We'll talk about that more next time. But this is very critical. This is what we were talking about earlier when we talked about these vital centers. Make sure that you appreciate the importance of the medulla for homeostatic regulation of heart rate, with the force, the contractility of the heart to the ventricles. What does vasomotor mean? Right, so vasomotor function, what we mean here, do you remember what the part of what system primarily regulates peripheral vasomotor tone? Autonomic, more specifically the sympathetic, so that kind of tells you where sympathetic innervation originates. But yeah, the vasomotor centers in the medulla regulate peripheral blood flow to a larger extent than any other system, in tandem with or in association with the sympathetic nervous system. And then the primary respiratory centers, what we call there's another dorsal and even a ventral system in the medulla that regulates the rate and depth of respiration There are also some systems up in the pons we'll talk about that contribute to regulation of respiration too. But later in your clinical courses, you're going to learn about, again, these brainstem patients and their peculiar patterns of respiration. You'll learn about Kussmaul rhythms and various other types of rhythms that are characterized with lesions, strokes, or other problems associated with the brainstem. The pons is this intermediary region here. You can see the anterior projection of the pons there. The adjective for pons is pontine. Always fun to say. Contains the nuclei for 4 of the cranial nerves, 5, 6, 7, and 8. And then I mentioned, by the way, pontine means bridge. So this is just sort of a bridging region of the brainstem. And I mentioned 2 of these centers that contribute to regulated respiratory rhythm and depth. Up until a few years ago, I could give you a putative function for each of these. I've pretty much given up because the researchers that look into the pontine respiratory regions have decided we really don't know as much about them as we thought. But in any case, you should know these 2 regions, the pneumotaxic and the apneustic. The current thinking is that these contribute to behavior or circumstance-specific respiration. If you're running, you're going to breathe more, not only at a higher rate, but the pattern of breathing is going to change as well. So it's thought that these pontine centers help facilitate your ability to breathe when you're talking, to breathe when you're eating, to breathe when you're running, and so on. I'm particularly fond of the midbrain, so that's my favorite brainstem region for a number of reasons. The midbrain contains several pedicles, and pedicle has a couple of different meanings. The cerebral pedicles are just extensive neural connections between the cerebrum, the spinal cord, and the cerebellum. And they include both gray and white matter. I should mention now, because I'll probably forget to do so later, that the cerebellar, not cerebral, but cerebellar pedicles are just massive white matter pathways between the cerebellum and the brain and the spinal cord. But in general, the term pedicle implies connector. It's a massive connection. We've already talked about the ventricles 3 and 4. The connecting structure is called a cerebral aqueduct. Remember an aqueduct, a Roman aqueduct? It was like a plumbing system. But I want to say a little more about this structure, the corpora quadrigemina. And this is that region of the brainstem that is so important in rudimentary, primitive processing of sensory information. If the thunder were to strike, I don't know, just outside the window here, most of us would jump, and perhaps our heart rate would go up. And my question for you is, would your response precede your awareness, or would your behavioral changes, heart rate, and maybe the jumping, would that be a consequence of your brain saying, that's a thunderbolt, potentially dangerous? Which would come first?
Reaction.
Yeah, the reaction. So my point here is, if you're driving along and a bird hits the windshield, you reflexively close your eyes and perhaps jump back long before you even understand what has happened. It's a reflexive response. When I say reflexive, I'm using that term in a very general sense. And that's because there are pathways from the eyes and from the ears directly to the midbrain. And they seem to play a role in these very, very rudimentary, life-sustaining responses that often precede conscious awareness of the process responsible for them. Now, the corpora quadragenita, you find 4 lobes here. There are 2 superior or paired bilateral superior colliculi and inferior colliculi. The colliculi chiefly process visual stimuli. The inferior colliculi chiefly respond to auditory stimuli. Anybody ever heard of blind sight? What do we mean by blind sight? It's actually an informal clinical designation. There are patients, there are not many of them, patients who are not able to see, but they don't have any field of vision, there's no illuminance at all, there's no luminosity in their awareness at all. But if you were standing at the back of the room and asked them to come towards you, no further signals, none of this clicking of the lips and so on, they would probably be able to avoid the desks and make their way back to you. That's one type of blind sight. How is that possible? It's related to our discussion of sensations and perceptions earlier. One putative explanation, as it turned out, that you'll find in the textbooks, but is completely incorrect. Nevertheless, it served my purpose here. Is that information is visual information? In other words, their eyes are functional, the optic nerve is functional. All those pathways are functional back to the brainstem. But what's not functional, for whatever reason, are the connections to the occipital cortex. So the brainstem is receiving visual stimulus and visual stimuli and responding to that stimuli, even though the individual is not aware. That's what we mean by blind sight. The brain, at the most primitive level, is able to respond to visual stimuli, but there's nothing processing that information in the higher cortex. How do you know if a baby can hear? How do you know if the child can hear? How are you going to test for the ability of a newborn or child?
You try to startle them.
Yeah, there's the startle reflex, but can you assume that if a child does not respond to a startle reflex that they're deaf or that they... No. What you will have is a little device. It's for otoacoustic emissions, and it's about the size of it's very small. Make them very small now, and we don't have much time. So I think this is a story best left for another time. But with that little device, you can at least test to see if the ear works. But let's say the child's ear works. Does that mean they're going to be able to hear? No. It means only the ear is working, but maybe the neural pathways between the ear and the brain are not working. They have cochlear implants for auditory problems. There's a child recently just had a brainstem implant so he could hear. He's got a little microphone here. None of this works. None of his ear, none of the pathways are intact. He was born without them. They put the little microphone here, and then they connect the wires directly to his brainstem. He can hear. But again, by virtue of this anatomy. We're out of time, thank goodness. And we'll pick up there later.